Alrighty, well, welcome everybody to September's, or this isn't September, good golly, August. The Missouri Occupational Therapy Association's August CEU. This is, I think, our fourth now. So Cindy's coming back to us from our first ever virtual CEU to give us this one on Medicare Part B basics. We are recording this webinar, so it will be available in the next couple of days on our MOTA website. We'll also be announcing our upcoming CEUs on that website as well. So you can always find the links to the CEUs, the recordings, the post-test, as well as the slides should all be posted on that. We've automated our certificate issuing, so you should get that almost immediately after completing the post-test. We're kind of going on the honor system where if you receive less than 80% on the post-test, so less than 8 out of 10, please go ahead and retake that test to make sure that it's showing that you have a competency in the materials. And so I will let Cindy go ahead and take it away.
Okay, well, welcome. Thank you everyone for joining us this evening. I know it's like, woohoo, Medicare Part B. Could we get anything more exciting than talking about Medicare Part B? So I am going to go ahead and I'm going to share my screen. Let's see, I need to, all right. Go. Okay. Can you guys see my screen?
Yes.
Okay. All right. So we're going to start from the beginning here.
And if everyone else could go ahead and mute besides Cindy, that'll make sure we don't have any feedback.
Okay. All right. So I am going to talk about Medicare Part B, but you know, the other thing that I really want to talk about is, you know, in Medicare Part B world, we really haven't had that many changes. All of the other areas have really started to do this focus on value-based care. And I kind of wanted to include that because I really feel that that's what's coming down the line for us too. So, you know, when we look at Medicare changes, as I said, Medicare Part B, we haven't had that many changes. Skilled nursing, anybody that knows anybody that works in skilled nursing, oh my gosh, the changes. Home health, so many different changes. But when you sit down and look at Medicare Part B, there have been some changes. And part of the reason that we've had these changes is because we're really moving from that value versus volume. You know, there's some people that talk about, even in Medicare Part B, it's going to be like, for those of you, do you remember Name That Tune, where it was like, I can name that tune in 10 notes, I can name that tune in 6 notes, name that tune, and you had to say, you know, and then you had to name what that tune was. Well, in a way, it's almost like, is that what's going to happen to us in Medicare Part B? Are we going to get a lump sum payment? We're not there now, but you know what? I think when you talk to people in the industry, I think that they wouldn't be surprised to see us doing some of that kind of thing, because we really are shifting to that value-based care across all settings. So as I said, lots of changes in skilled nursing and home health, and the focus on the quality, not value. Now, in Medicare Part B, we do have the MIPS program, and I'll talk about that a little bit at the end, but there are not a lot of occupational therapists that are participating in that, mostly because most of us work for rehab agencies and things like that, and we're not eligible. But it's interesting when you look at that, you know, perhaps that's something that in the future we will be able to participate in that. Okay, so we look at quality because that's what we need to be focusing on. If you're working in like a skilled nursing facility, assisted living, those kind of settings, you should be aware of what CMS looking for. And then what can we as therapists do to help improve or influence their quality scores? I mean, we have such value. I think if anybody doubted what our value was, look what's happened during the pandemic. So as you know, I'm an occupational therapist. I forgot, I didn't introduce myself. I've been a therapist since wheelchairs were wooden, and I mean that literally. 39 years ago, I graduated from the University of Kansas, so I'm a Jayhawk, yay. And I have worked in basically with older adults my entire career across continuum, acute rehab, acute, skilled nursing, and my current position, I work in outpatient world. Med B world in mostly independent living, assisted living, and memory care. Well, in one of our buildings, they decided when all the COVID cases started coming, they decided that therapy was not considered an essential provider. And so we were not allowed to go into that building. I don't know if anybody else had that same experience, but I will tell you, we are now back in that building. And I think what everybody told us was like, oh my gosh, I mean, we knew therapy was important, but we noticed that the residents were just declining. They really missed therapy, if nothing else, just for that social engagement. And it was funny because when we went back into the building, even people who hated therapy, or not hate, but didn't care for therapy, all of a sudden they were like, woohoo, let's do therapy, because they missed that human contact. So what can therapy do? As I said, we've really shown that there's a lot that we can do to improve the quality of life and improve their quality scores. But what we're looking at is I like to talk about doing the right care to the right client and the right amount at the right time. So not everybody needs therapy. Not everybody needs the same amount of therapy. And I think sometimes as I do some documentation reviews, I'll look at charts and it's like, oh my gosh, is this the same patient? Because it looks like everybody's getting the exact same thing. Our plan of care should be individualized based on what this particular patient needs. So the things that we look at, we document outcomes in the areas of ADLs, IADLs, behavior, psychosocial skills, vision, and functional cognition. We all know that. We all know that. But it was interesting because I was talking to a relatively new grad this evening, and she was saying, she just called for some consultation, and she said, I have to do a peer-to-peer review. Can you look at my evaluation and tell me what do I need to say? So this was a gentleman who had fractured his shoulder from a fall, was just removed from the sling 2 weeks ago. And she had range of motion listed on that side, but didn't compare it to his unaffected side. And the only functional skill that she talked about was that he was having difficulty making the bed. And I talked about, well, what other things is he having difficulty with? And she rattled off this whole list of things that he couldn't do. And I said, the reason why you're having this peer-to-peer review is because when I look at this evaluation, I'm not seeing any of that stuff that you're telling me. I understand, I know, somebody who has a humeral fracture, who's 85 years old, who lives alone, I know what he has to be able to do. But you have to connect those dots and make it so clear. And I think, she said, okay, well, that really helps. Our documentation has to support what we're doing. Okay, I know some of you may have seen this before. I love this slide. I was at the ATM the other day and an elderly lady approached and asked me to help check her balance. So I pushed her. Now, I just think that that's really funny because, that's skilled, right? Checking balances. I know that that's not what they're really talking about. My daughter makes fun of me because we walk around the neighborhood and there's an elderly gentleman that lives in our neighborhood and he walks with a cane and he clearly has Parkinson's and the cane is not the right height. And sometimes he walks his little dog. And my daughter's a physical therapist. And I said, I'm going to just tell him his cane's at the right height, wrong height. She's like, no, don't say anything. So the other day, she wasn't home. I was walking. I stopped. I adjusted his cane. He said, oh my gosh, that's so much better. And then we just had this very nice conversation. But am I the only one that when you're out of the store, well, we don't go to the stores, but when you're out in public, don't you just stop everybody? Oh, can I adjust your cane? Maybe I'm the only person. So anyway, what we have to show is what we're doing is skilled. So what is the definition of skilled? So this is, quotes. If the inherent complexity of a service prescribed for a patient is such that it can be performed safely and or effectively only by or under the general supervision of skilled rehabilitational personnel, the service is skilled. And then the whole reasonable and necessary that we're going to talk about in a few minutes. So I always bring up the example of, for example, writing the news step. And I think sometimes we see that more in PT, or I might see that somebody stood for 3 minutes and batted a balloon. Okay, well, all right, that's great that you did that, but why did you do that? What are you working on? So, well, I'm working on balance and reaching outside of basis support. Okay, so if you choose to use balloon volleyball, that's fine, but what you have to show is why is that skilled and how does that relate to this patient's deficits and what your goals are. The same way if you're using the new step, what makes it skilled? If that patient comes in the wheelchair, you help them onto the new step, they adjust everything and they ride it for 10 minutes and then they say, okay, I'm done now. Is that skilled? I would argue no, it's not, because it's not taking our skills. But now, so for example, I do have a patient that we're seeing and her physician specifically said he wants her to ride the new step. She just had congestive heart failure and a heart attack. She is just really kind of a mess. And so we came downstairs, we got on the new step. She needed assistance to get on. I checked her vital signs. We talked about what resistance level she needed to be in. Every minute I was checking her vital signs. I was listening to her breathing and I was really there. We were intervening and I said, okay, we need to stop. I know you told me your goal was 3 minutes, but I'm looking at the increase in your heart rate. I am looking at your oxygen level going down. To me, I'm now doing skilled therapy. So I think a lot of times we all know that, but the problem is we don't necessarily show that in our documentation. So don't forget to make sure that what we're doing is skilled. And that is something that has not changed since Med B CAP. When Wendy and I first were occupational therapists and Med B CAPs were first put into place a couple years ago. But Wendy and I were both 5. I was 4 and I think Wendy was 5 when she first became an occupational therapist, because we're really not that old. Okay, so the next thing I'm going to talk about is I'm going to talk about the Med B CAP. All right, no, wait. Didn't we get the cap? Isn't that gone as of February 2018, right? That was a big victory. Woohoo, no Medicare Part B cap. So there's no cap, right? Well, yeah, there is, okay? Technically, there's no cap, okay? However, therapy payment is still limited to $2,080 for OT, and then PT and speech have a shared cap of $2,080. Now, that doesn't mean that you have to stop when they get at $2,080. And when you talk to people that review, if they say, you know what, somebody got up to $2,075 and they stopped, and I'm looking at the notes and I'm not seeing that reason for stopping, are they stopping because their goals were met, or are they stopping because they didn't want to go over the cap? Okay, so this $2,080, it's just, all it says is when you hit that amount, you need to put the KX modifier. And that KX modifier, it still exists even though there's no cap. They were very clear and said the KX still needs to go on there. And when we put that KX on the billing, it says that we feel that the services that we are providing are skilled, reasonable, and necessary, medically necessary, and that they should continue to be reimbursed by Medicare, okay? So, you know, most of our EMRs, it has, like, I know our EMR, when you get to that 2,080, a little box pops up and it says you are about to exceed the KX. Do you wish to continue? We click yes, and then we move on. Just know that that's just, it's a kind of a warning. It doesn't mean stop, but it just means it's a way of letting you know you need to put that KX modifier on. Okay. Now, then there's the threshold. Remember, we don't have a cap, but we still have the KX, and oh yeah, we still have a threshold. And it used to be $3,700, but now it's only $3,000. PT and speech still share a threshold, and OT has its own threshold. Medicare has the ability to review any claim at any time, not just because they've exceeded 3,000. But what they do say is that services above this threshold may be subject to manual medical review. And this therapy cap applies to all Part B outpatient therapy settings, including hospital outpatient departments, which were previously excluded. And Medicare has up to 7 years to go back and look at your claims. All right. So just to kind of, let's go over that again. In 2018, February of 18, when they got rid of the cap, they said you still have the KX, and we're changing that 3,700 threshold to 3,000. And what they said is that you may be required to submit documentation after your patient has exceeded the $3,000 threshold. It is your responsibility as a provider to make sure that your documentation supports that the services that you're providing are skilled, reasonable, and necessary. The claim may be subject to a post-payment review where they're going to, and it may be that they're going to pull one note. So you exceeded the cap on the 5th of June. And you continue to see them twice a week or 3 times a week. And they ask for the note for the 16th of June. They're going to look at that note for the 16th of June, and they're going to make a decision. Are we going to continue to pay? Or are we going to ask for additional documentation? So the one thing that I always tell people is that each note should be able to support what you're doing. Okay? So if the claim is denied, Medicare will not pay for the services. You have a right to appeal, and you have to meet your deadlines, because if you miss a deadline in the appeal, they're just not going to pay for it. Okay. So I'm sorry about that. So who are they going to target? In years past, what they've said is they're going to target those people that either stop just short of the 3,000, or those people that just keep going. And when you look at the number of patients that they have that have exceeded that 3,000, it seems like everybody goes over. They weren't even paying attention to that. So they look at the number of claims that you have in comparison to your peers. Do you have a lot higher number of claims that go over the 3,000, or do you just stop short of that 3,000? They also look at how long you're seeing your patient for each visit. So you're seeing patients for 90 minutes a visit. They feel sometimes, now there are definitely times when that's appropriate, but your documentation needs to support that. Okay. So just wanted to talk about that. So let's talk a little bit about the impact of COVID on the cap, because I've heard people say, you know what, there's no cap. We don't have to worry about MMR. We don't have to worry about 3,000. We can see anybody for as much as they need because of COVID. Now, there's a lot of theory and speculation that there will be less scrutiny on those that exceed that $3,000 because of COVID, but we have not seen that put in writing. What we have encouraged people to do, I mean, I think we've all seen this. Patients that haven't gone any place, maybe they used to go to the dining room for their meals, and now they're not going to the dining room because they can't go to the dining room. Maybe they used to go out with their family every weekend, and they can't do that because they can't leave their facility. Maybe they used to come into our outpatient clinic, and they're not doing that because their family says, I don't want you going anywhere near that hospital. So when they finally do come back, what do we expect to see? We expect to see these people to be significantly debilitated. That's what happened in that building where we were gone for 3 months. So, and unfortunately in that building, we also had a number of people who did develop COVID. So we couldn't come back in with those people that were post-COVID patients and think, great, we're going to see you for an hour at a time, because they could not tolerate. 15 minutes was about what they could tolerate. So we've not seen anything in writing, but I think that, you know, if you use common sense and you can document, you know, why you need to continue to see that patient, I think that makes sense. So I gave you a quote. This is something that we've used, something similar to that. Due to in-apartment quarantine restrictions, patient presents with generalized weakness and decreased activity tolerance, which places them at risk for falls and further decline in function. Skilled therapy is required to keep them safe from blah, 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 blah. And I think we address not only physical, but also psychosocial and cognitive. So, you know, the more that you read about the people that have had COVID, they're really talking about the cognitive deficits. Obviously, we were prepared to have the respiratory deficits, but we're really seeing a lot of cognitive deficits from people who had COVID. But what about those people who live on a memory care unit and they haven't seen their family for 3 months, and they don't understand. And they used to be able to go and get their hair done and used to be able to go and eat in the dining room. And now they can't do any of those. Don't you think, I mean, we're seeing more depression and all of those kinds of things. Those are things that OT can address. And I did include a reference in here from the Alzheimer's Association. I am a community educator for the Alzheimer's Association, and it's a great resource. So just, you know, I think if you work with somebody who has dementia, I think it's a great thing that you can kind of bring that up and look at some of the things that are on there. Okay. Coverage for students. I always bring this up, even though it really hasn't changed in a while. I think it's important because as clinicians, we have to understand what the rules are, okay? Under Medicare Part B, technically, a student is not able to bill unless the qualified professional, and I put this is in quotes, is present and in the room for the entire session. The student participates in the delivery of service when the qualified practitioner is directing the service, making the skilled judgment, and is responsible for the assessment and treatment. So we know we have students that come into our Med B settings, okay? It can be a really great learning experience. But while that student is working with my patient, I'm not working with anybody else, okay? If I do, it's now group therapy, okay? It's gotta be the student and myself are there working with that patient. And that patient has to understand that this is a student and I'm ultimately responsible, okay? Not doing other tasks. I will say sometimes I'll take a phone call, I might do some notes, but I'm really there, I'm listening, I'm watching what's going on, okay? And as the therapist, I'm the one that is responsible for the service and I have to sign the documentation. I let my students go ahead and write the documentation, but we review all of that. That's as if I was writing it. So I need to make sure that whatever they say, I agree with, okay? So I'd like to go over that. I know it really hasn't changed, but I think it's something that I think people bring up and have questions about. Okay. One of the things that is changing and did change as of January 1st of 2020, as a result of the Balanced Budget Act of 2018, where they got rid of the caps, everything has to be budget neutral. So what they said is because we're gotten rid of the caps, so you're gonna be able to see these patients more. So as a result, we gotta make it budget neutral. So we're gonna start reimbursing you at 85% of the normal rate when the therapy is provided by an assistant. Now, at first we were like, wow, what's going on? This currently until January 1st of 2022, we're still getting paid at that same normal rate. But when at least anything greater than 10% of the visit or of that unit is being provided by an assistant, you have to use the CO modifier, which means more than 10% was provided by an assistant. Now, one thing that we did get is that this is by the unit. Okay, so let's say, for example, right now, I have a building where I can't go in because the building won't let anybody in that isn't routinely in that building, and it only goes to that building. So I have a full-time coder that's in that building. I go and I do an evaluation, but I'm standing, and I literally do this, I'm standing outside the building because I can't come into the building. My patient is at the window, we open the window, I'm wearing my mask, my assistant is in there, and I'm saying, you know, can you raise your arms up? Can you do this? Okay, let's do a transfer. And I'm telling her exactly what to do. I am right there, I'm not in the building. I could not do that without the assistant, okay? But because I'm there, and I'm doing all of that portion, we don't use the modifier, okay? So when both the therapist and the assistant are doing what in that instance I would call concurrent, we don't have to use the modifier. But now I finished my portion of the evaluation, I wave goodbye, I leave, and the assistant continues to treat that patient for that treatment. So let's say she does 15 minutes. that treatment is billed with that CO modifier. Okay, so does that make sense? So as I said, as of right now, we're getting reimbursed for the full rate. As of January 1st, 2022, it's going to be reduced by 15%. So we'll only be getting 85%. And the rationale is if you go to a nurse practitioner, a physician's assistant, Medicare pays that person less than they pay when you go to the physician. So they're just trying to be, treat everybody the same. Okay. All right. Telehealth. Last time I talked to you all, we had just gotten approval for telehealth, but for Medicare Part B. But if you worked for a rehab agency, you weren't able to do that. Well, then they just kind of snuck it in and said, oh, wait, here it is. Yeah, you can. So we are currently able to provide telehealth services to Medicare Part B patients. Allowed billing by PT, OT, and speech, but it doesn't cover some of the dysphagia codes. So if you're an OT that does dysphagia and bills with those codes, it doesn't allow those codes. And that really does make sense because that's something that I really wouldn't be assessing someone swallow via video, okay? It was initially was supposed to expire at the end of July, I think the 25th of July, but they extended the public health emergency. So right now, it's extended until October 23rd of 2020. You do need to have a consent, and I gave you a sample consent. The patient requested and has consented to blah, 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 blah. You need to have that somewhere in your documentation. So we actually, in our documentation, we have a telehealth template, and that pops up on every visit note. The other thing is, all of the visits that we've done for telehealth, they've been established patients. We haven't done any new patients. If you are seeing a new patient, you do have to verify that you're seeing Susie Smith. So you want to see Susie Smith's insurance card and a picture of her driver's license or some sort of photo ID so that we know we're actually working with Susie Smith. Okay? We would love to be able to continue to do telehealth. Okay? I think a lot of people have seen the value of telehealth. I don't think every visit needs to be done under telehealth. But, you know, if you're in a rural area, it certainly makes sense. If you are, you know, a therapist and I have an assistant that is doing, you know, all my visits and I physically can't make it into that building to do that 10th visit, soup visit, if we can do it through telehealth, that's great. It's just an opportunity for us to be able to provide a different type of care. Okay. Medicare Advanced Beneficiary Notice. I think that this is something that people don't really understand what an ABN is. An ABN basically is a form, and I have some references at the end that talk about some of these, this particular form. And you can go online and you can modify it to your environment. Somewhere, someone in your billing department has a copy of the ABN. But this ABN basically says is that, you know what, this is a Medicare patient, and I can't ask them to pay for something that I think Medicare would pay for unless they sign this. So let's say I'm a private practice OT, and you know what, I'm doing great, love what I do. I don't have to worry about insurance and all of that kind of stuff. And a Medicare patient comes to see me. That's fine, but what I need to do is I need to have them sign an ABN that says they understand that Medicare is not going to pay for it, okay? I can also use this when I have a patient who says, oh, Cindy, you're the best therapist, and I say, oh, well, of course, and it's time for you to be discharged. I have a patient right now that we've been working with for a while, and he's really complicated. He's a physician, and it was time for us to decrease his frequency to 1 time a week, and we're just gonna see him for a couple more weeks, and then that's it. And what he said is that I wanna continue. I think the therapy is really helping me. I agree, but I also feel like we're at that point where we could do it just once a week. So he can continue to get that therapy, but what I'm going to do is I'm going to have him sign an ABN that says, you know, I feel like it should only be covered one time a week. All right. You know, I say you're ready for discharge and they want to continue on, or the physician says, I want you to continue with this patient. It's just, it's a way of kind of protecting ourselves. So here is part of, I just cut and pasted some of this. So if it's this whole form, if Medicare doesn't pay for D, in this instance, it would be occupational therapy listed below, you may have to pay. Medicare does not pay for everything, even some care that you or your healthcare provider have good reason to think you need. We expect them to not pay for this below, and we write why we don't think that they're going to pay for it. I don't think it's skilled, reasonable, and necessary. I don't think he needs this frequency, whatever I think it is. Or, you know, patient chooses to not, you know, have Medicare be billed. So option one, I want the therapy listed above. I may be asked to pay now, but I also want Medicare to be billed for an official decision on payment. Okay. I understand if Medicare doesn't pay, I have to pay and I can appeal. But if you make me pay in advance and Medicare says, yeah, you're right, we should be paying for that, then I have to pay the patient back. So that's option number one. I still want the therapy. You can ask me to pay now, but if Medicare says that you should have been billing Medicare, then you have to pay that back. Okay, option number two, I want the occupational therapy listed above, but don't bill Medicare. You can ask to be paid now, as I'm responsible for payment, and I cannot appeal if you're not billing Medicare. So in that instance, I don't want to bill Medicare. The patient says that's okay. I don't care about that. I have long-term care insurance. You're a private practice therapist. I'm fine. Just go ahead and bill. They would do option number two. And then option number three, I don't want the therapy. I understand with this choice, I am not responsible for payment and I cannot appeal to see if Medicare would pay. So if they choose that, I can't submit this and then have them come back and say, oh, well, Medicare would pay. Well, let's continue on. Okay. So I wanted you to know about, and there's a great source, resource on the AOTA website that talks about the ABN, and then it has links to the form and everything. Okay. All right. Now let's spend a little time talking about Jimmo versus Seblius. And I know some of you have heard me talk about this before, but we still get a lot of questions about this. This happened back in 2011. And basically, you've heard me talk about skilled, reasonable, and necessary. Well, what this settlement said is that skilled, reasonable, and necessary, that's still there, but it doesn't say that they have to show improvement. Okay, so there were multiple, I think 11 plaintiffs, yes, 5 individuals and 6 organizations, including the Alzheimer's Association, MS, blah, blah, blah. They brought the suit that said, without the skills of a therapist, I'm going to decline. So Medicare, you should continue to pay. They reached an agreement on October 16th of 2012. The judge approved the settlement, certified nationwide at a fairness hearing in January of 2013. So this has been around since 2013. And it's kind of funny because every now and then I think the New York Times or somebody like that runs an article and a family member will bring it in and it says, you know, my mom has Parkinson's. And so because of this, you have to pay, my mom's going to get therapy for the rest of her life because she has Parkinson's. Okay. Yes, she does have Parkinson's. And this settlement does talk about this. But what it says is coverage depends not on whether or not they're going to get better, but whether or not skilled care is required. And along with how reasonable and necessary is that? So is it reasonable and necessary for your mom to get occupational therapy because she has Parkinson's 3 times a week for the rest of her life? I don't think so, okay? So it's kind of this game that, it's not a game, but it's this, we have to kind of figure out at what level can we maintain them? keep them from getting worse, but be as cost effective as possible. So for example, I am working, well, actually I was working with a woman since COVID. She hasn't come into our clinic because she's 70 years old. She lives with her 93-year-old mother, very medically complex, the two of them. And she has a really complex medical history. And so she came, we did therapy. She did beautifully. I discharged her. 3 months later, fall, came back. We did the same thing, got her back, discharged her, declined again. So what we determined is that, you know what, she's a great example. As soon as I discharge her, she starts to decline. So what we did is I got her to where I felt this is her maximum level of function. So now what I'm going to do is I'm going to start figuring out what's the minimal amount of therapy that I can do to keep her on that level. And what we determined is if she comes to see me every other week for 30 minutes, that's all it takes. And by doing that every other week, 30 minutes, occasionally she might go out of town, I might go out of town, so sometimes it's every third week. We have maintained her and she has done beautifully. I talked to her the other day and she said she's so weak and she's really worried, but she and her mom are afraid to come in. Her brother won't let anybody come into the house because they're afraid somebody's going to bring in COVID. So I can only imagine what she's going to be like when she finally gets to start therapy. But so what we determined is that the skills of a therapist are needed to maintain her level, okay? If she would decline without the skills of a therapist or assistant, the services should be covered. So how do we determine that criteria? It's based on their unique condition and needs. It's not just because they have a particular diagnosis. She doesn't have one of those particular diagnoses, but I talk about how complex her medical condition is. So services would be considered skilled if they're needed to maintain, prevent, or slow deterioration, and if they can only be provided by skilled personnel. So in one of our buildings, we have a gentleman who has Parkinson's and he gets restorative therapy. Now, restorative therapy, he's awesome. He is amazing, okay? And with restorative therapy, he's maintaining this guy. They walk, they do everything. And his wife said, oh my gosh, because of this, we should be billing this to Medicare. And what we said is he doesn't need the skills of a therapist. He's maintaining with the skills of this therapy aid. So we can't justify that. Now, if he has a decline in function, we will certainly pick him back up, get him back to that level, and then put him back on restorative, okay? All right. So if the services can be provided by a non-skilled personnel, then it wouldn't be covered, okay? And once again, is it reasonable and necessary? I can remember one time we had taken over a contract and I walked into the building and there was a patient that had been seen for 9 months for a splint for her hand. She was status post-stroke, was pretty much dependent for everything. They had given her a prefab splint, one size fits no one, and she had been seen for 9 months. Splint still didn't fit, was never going to fit. And, it wasn't appropriate for her to continue on. We actually ended up at that point, we just got rid of the splint. She ended up having to go into like a palm protector with an insert, got her to the point where staff were able to put that in and out. The reason why they said she needs the skills of a therapist were because nobody could get that splint on. They said, oh, only therapy can put the splint on because the splint didn't fit. So I didn't feel like it was skilled, reasonable, and necessary. Okay, so those are the words that we still need to show. All right. Other things just to kind of highlight, sometimes it may be that we're just going to design that program, or we're going to periodically, somebody that's getting restorative therapy or maintenance, or somebody who's living home with their family, and they're going to come into our hospital outpatient clinic, once every 3 months. We're going to tweak their program. Great, we're going to do this. We're going to change this. All right, you're having more trouble, so let's do this and this. We might see them for a couple weeks, discharge them back, they go home, okay? that would be appropriate. So sometimes it's just, I'm going to see them periodically to tweak their program. Okay. Now, if they exceed that non-existent therapy cap, the same rules still apply. Do they still need the services? If so, we're going to continue to see them. Okay. So when we're documenting, what we need to do is include their medical history, what we're doing that makes it skilled, how they're responding, what we're going to do for future care. I'm going to decrease them to once a week, and then once every other week, and then once a month. So put that in your documentation. And then why what you're doing is so complex. Because of the complexity of their medical condition, physical condition, cognitive disability. Why? Why do you need the skills of a therapist? Okay? All right. So now let's move on to comprehensive error rate testing. See, do you like my little CERTs down there? I had to search really hard. Does anybody remember CERTs, those breath mints? Okay. All right. So CERT testing, comprehensive error rate testing. And basically what they're trying to do, Medicare is trying to figure out, are we providing services that are medically unnecessary? All right. And this report allows CMS to determine the most common incorrectly billed or documented coverage areas and create targeted educational materials to address them. The goal is to reduce some of these common errors and reduce the overpayments. So PT, OT, and speech. So they're really doing this to try and save money. So these are what they find are the most common errors. Okay, number one, missing certification or recertification by the physician or lack of timely certification. So timely certification, ideally 7 days, because you know, we all know that happens. Timely certification within 30 days. But you know what? There's some physicians that we just can't get it, especially right now. We have physicians that haven't been in their office. So we may have a cell phone conversation with them. I'm going to document that, but I may not have their signature because they haven't been into their office. So those are the things that we need to make sure that we're documenting that. And then as soon as that physician comes back into their office, that we get their signature and attach an explanation of why it was so delayed. So missing certification or recertification, missing or an incomplete plan of care, things that have to be included in every plan of care. What are their diagnoses? Long-term goals. You don't necessarily need short-term goals, but you should have long-term goals. Long-term goals, as we know, goals that are going to be accomplished by the end of the duration of treatment. The type, the modalities, what are we going to do? The amount that we're going to do, our frequency and our duration, the reason for a referral, and then our objective findings, just to support the plan of care. Okay, another common error that they find is missing significant plan of care changes and recertifications, all right? So we're doing this, going along, and then all of a sudden, our patient who was doing really well had a stroke, didn't go to the hospital, and they went from here down to here. And now we're needing to add, they were ambulatory, and now we have to do wheelchair positioning and all of these things. At that point, we need to get a recertification because we're adding new long-term goals. And when we do, we need to get, when you add long-term goals, you need to get a recertification. Another common error is documentation does not support medical necessity. Patient rode the new step for 15 minutes, transferred with standby assist. Okay, why? What are we doing? How were they impaired? That's not in there. It doesn't support medical necessity. And then documentation of treatment provided doesn't match their billing. I'm billing for balanced neuromuscular reeducation, and nothing in my note talks about the balance training that I did. So those are just some things that I wanted to go over. If you were going to focus on, you know, if you're doing your QIs or whatever, these are things that, these are common errors. So these would be things that you want to make sure. Do you have a mechanism for making sure that you have physician's signature on all of your plan of care? Okay, I just think it's helpful to know. Okay, and I just wanted to go real quickly over things that we have to include in our evaluations. Obviously, diagnosis, frequency, duration. Did they have any previous therapy service? What was their previous level of function? and not just independent. What were they? Were they driving? Were they working? Do they live by themselves? One-story home, whatever. Self-reported health status. That is a requirement under Medicare Part B. Good, fair, poor, etc. What kind of social support do they have? And then obviously objective data. And our progress notes. Objective data, progress made towards goals, and revision of the goals if appropriate. Assessment of the progress and need for continued therapy, and at least every 10th day, every 10th visit, a progress evaluation must be done. The patient needs to be seen by the therapist. Okay? 8-minute rule. And I know I'm going through a lot of this quickly, but we all know all of this. I think sometimes it's just helpful to remember. The 8-minute rule. Now with EMRs, it's really not that much of a big deal. But remember, when we're billing, we're looking at total number of minutes that we're billing. So if we're billing between 1 and 7 minutes and that's all, we can't bill. It has to be at least 8 minutes in order to bill it for 1 unit. 8 to 22 minutes, 1 unit, 23 to 37, 2 units, 38 to 52, 3 units, and so on and so forth. So it's total time. So if I saw somebody for 20 minutes of self-care and 20 minutes of therapeutic exercise, 20 and 20, let's see, that would be 1 unit, right? No, no, no. It would be 3 units because the 40 is between that 38 and 52 minutes, okay? Our EMR will choose whichever is the most expensive. They will put the 2 under that one and 1 on the other. So however your EMR goes. I think the value to knowing this is sometimes explaining to people, you know, if you're seeing somebody for 37 minutes, okay, I can only bill 2 units. Can you do another, you know, 3 to 5 minutes? And then I'm going to bill another unit. Now, remember that we're not trying to bill everybody for 23 and 38 and 53 just so, woohoo, I can bill another unit. It should be about 50 minutes, about 30, about 45, about 60. But they just tried to make some rules so that we can have some understanding of when to bill, okay? All right, the new cognitive codes that went into effect on January 1st of 2020, 97129 and 97130. Just the difference is, the initial 15 minutes, you're going to bill under that 97129, and then each additional 15 minutes, you're going to bill under 97130. A lot of times when I'm billing cognitive, I'm not really necessarily doing like quote unquote cognitive. I'm doing functional skills. So I'm working on a medication management task. I'm doing cognitive. I have a patient who has cognitive deficits, but I'm doing that because of functional disability. So I will, a lot of times, I won't necessarily bill under these cognitive codes. Instead, I'll bill it under 97535 or 97530, the therapeutic activities. But I wanted to let you know because those 2 codes are a little bit different with the 15 minutes. Okay, MIPS, I told you I was going to talk about that. That's our quality payment program, merit-based incentive payment system. What a mouthful. And as OTs, we report on 2 items, quality and improvement activities. And if you participate in MIPS, you can earn up to a 9% bonus to your payments in 2022 if you're successful, or up to a 9% deduction if you're not successful. So you want to be successful. You may be eligible if you work in Medicare Part B settings, but if you bill through a facility like a rehab agency or a skilled nursing, etc., you are not eligible. So I gave you a source. You can go on there and you can check to see if you're eligible. Do you bill by your NPI number? I have an NPI, but we don't bill. I work for a rehab agency and we bill for that rehab agency number. So I, at this point, am not eligible, okay? But if you do well and you address things, there is money there and you can actually increase your payment. Okay, all right. And I want to stop with this. I need everybody when you get off of this, don't hang up now, wait until the end, but I need everybody to take action tonight. They want us to have action by tomorrow. They're proposing a 7 to a 9% cut in Medicare Part B reimbursement effective January 1st of 2021. And the reason for that is to achieve that budget neutrality as a result of increased payment to primary care physicians. Now, we support primary care physicians getting their pay. We don't want to say, we're not saying don't pay the physicians, pay us. But I don't know about you guys, but I can tell you, we can't afford a 9%, even a 7% cut. We'll go out of business, okay? So HR 7154, protect access to therapy services, support the Outpatient Therapy Modernization and Stabilization Act. Please, please, please write your representative, ask for their support. You can go onto the AOTA website. You can also go to like I belong to NARA and I can get it from NARA. So there's different places that you can get that, okay? All right, here's some references. And then that's Avery. That's my youngest granddaughter. For those of you that know my daughter, Katie, who is also an occupational therapist, but she works with pediatrics, that's her daughter. So, okay, I'm gonna stop sharing my screen, although I'm sure you could all look at Avery for a really long time. Okay, all right. Okay, so the question about the extending the flexibilities through 12/30/2020. I have, it is some of the insurances and actually the governor has nothing to do with that. This is public health emergency. It's signed nationally. So we're really hoping that that will happen, but you're exactly right. Some of the insurances, yes, they have extended that. And the other thing to know about that is a lot of the insurance companies are waiving the copay too, okay? Not only for telehealth, but also for patients that come into your clinic. We have some of our managed care companies that are waiving the copay. Not everybody, but some of them are, okay? And Clarice posted the AOTA link, all right? Okay, all right, questions. Okay, so it's according to my, it's 7:58 according to my clock. Phew, that's a lot of information to get through in an hour. And as I said, I know a lot of this is not new information, but I think there's just been little tweaks here and little tweaks there. And I think it's sometimes it's just helpful to sit down and, you know, like the ABN, if you don't use that all the time, you know, I'm not sure that I would really know about that. So, and I just want to say, you know, all of my references are from the AOTA website. There are just amazing references. I mean, it's funny, the company that I work for is owned by 2 PTs. And so whenever anything comes out, it's like, I always race to see if AOTA has it up before APTA. And like when they extended the public health emergency, AOTA had it before APTA. Yes. So, because they're like, I didn't see that. I can't find that. Well, here, let me send you my source at AOTA. So, okay, questions.
Cindy, one of the things that I've been trying to work on is having more accurate diagnosis coding, especially, I mean, because even in acute care, we do bill Medicare Part B for our observation patients, and they always tell us they want generalized weakness, debility. But from what I'm reading on CMS, they really want more accurate coding, not so much symptom coding. So do you have anything in your EMR to help with more accurate diagnostic coding through the ICD-10, or how do you help clinicians with that?
You know, that's a great question. And I think that that's something that a lot of people struggle with. And it goes back to like when we were first working with people, you know, who's had a stroke. And what they would say is, you're not treating the stroke, you're treating the deficits that have occurred as a result of the stroke. So I'm old school, so I know 438.22 and 21 are late effects of CVA, dominant versus non-dominant side. So my EMR, I'm able to put that in, and that comes in with the ICD-10 code. But you know, they really do want the specificity you know, right versus left, new, old, all of that kind of stuff. So, but I also think it depends in your setting. In your setting, Clarice, especially, you know, in acute care hospital where you're building those 23-hour observation patients, you really want to be specific. Now, the good thing is a lot of times you have those in your EMR because you're in a hospital, and so you already have those ICD-10 codes listed there. Okay? All right. What else? Okay, I can't tell if Lindsay and Wendy are asleep or not, but hopefully
I'm awake.
Okay, you're awake. Good, good, good. All right. So hopefully you got some useful information, or maybe it was just like, okay, you know, I don't really care about the Blues and Kansas City is playing the Cubs, but you know, I can watch that and find out what's going on with that later. So I'll go listen to Cindy talk. Woohoo! I do appreciate you guys joining. I would have felt really bad if I got out, and for a while there, I was like, oh, there's nobody. And then finally Lindsay joined. It was like, oh, yay, somebody's here. Yay. Very excited. Ah, so cute. So I do appreciate you coming. As Clarice said, you do need to take, in order to get the credit, you need to take the test. The test, I covered everything. Did you, Clarice, did I cover everything that was on the, okay. So you should.
And it's all in the slides too.
Okay, yes, I tried to make it not too tricky. There was just, you know, I think there was one question about changing short-term goals, so I threw that in there. You don't have to have short-term goals, you have to have long-term goals, okay? All right, Clarice, anything you want to wrap up with?
Not right now. I do want to put a little bit of a plug. We have, if you haven't seen, our virtual conference is coming up in November. So instead of it just being a couple-day event, we are extending it out through the week. Most of the CEUs will be offered either on the weekends or they'll be offered in the evenings, I think from like 6 to 9 p.m. So the window to submit a proposal has closed, so we'll be announcing those sessions here soon. But that's going to be the benefit, at least of this year being virtual, is it should be a little more accessible to those of us who have full-time jobs, can't always get PTO, that you'll be able to kind of tune in the evening. The hope is that we will be able to get those recorded and posted and sell them as packages as well. But so stay on the lookout. Our Facebook page is always being updated with information. We've got a Facebook event page, and then also our website has that information. We're working on our September speaker, but there will be one. So if you guys are wanting to speak, or if you know someone at work who would be a good speaker, they don't have to be a MOTA member in order to present, just to attend. So feel free to shoot me an email. I've got my email over the website, and I'll post it here as well. Otherwise, I really appreciate all of you guys who keep attending. I know many of you come every single month, and that's great. So thank you for being MOTA members.
All right. All right. Have a good evening. Now go Blues, go Royals. Cardinals will hopefully play tomorrow. All right. Okay. Take care, guys.
Have a good evening.
Sunday, thank you.